Hi, everyone. Welcome back to the Mind Movement Health Podcast. Today on the show, I have Associate Professor Sanjay Warrior. Welcome to the podcast.
Thanks for having me, Kate. Appreciate it.
Well, I'm super excited to have you on today because we're going to be talking about breast cancer. But before we dive in, can you please introduce yourself to our listeners?
Yeah, definitely. So I'm a associate professor at Chris O'Brien Lifehouse, which is a hospital in Sydney. I'm associated with Sydney University through the RPA Academic Institute as well. I've set up a master's with Sydney University for breast surgery and or co-founded it with Andrew Spillane. And I've also been a past president of our breast society as well.
Amazing. So you are very highly qualified in this area to be chatting about this topic. And today I wanted to dive into prevention, but also treatment. And, maybe it's just something that I've read, but, I've seen stats that have sort of shown that breast cancer is getting more prevalent. But, you're the expert. Is this the case?
Yeah, look, I think if you look at trends, we definitely if you go back far enough, we were talking about rates of 1 in 9. It's now dropped to 1 in 7 with time over a period of time. That it includes Aboriginal data as well and better recording. But it's ultimately if we put 6 people plus yourself, you put your 6 friends in a room, one through their lifetime will develop breast cancer. And there is no doubt that the higher rates of breast cancer that we see are generally between 50 and 74, but we're not uncommonly seeing breast cancers between 40 and 50. And there are rates demonstrating both definitely around the world where we're seeing increases in that group. And we're also seeing probably around that 10%, slightly less than 40 developing breast cancer as well. So it's not uncommon for us in our practice to be seeing young women in their 30s with breast cancer. Is it the commonest presentation? No, but it's still something that we see.
Mm. Well, I'm sort of in the rehab space. So I'm in the Pilates, but I work with a lot of women post, I've got a client at the minute. She's 45. She has breast cancer. She's currently receiving chemo, but still having classes. She's had an operation. And so she's still getting courting and stuff happening. So we work on that in the class and stuff too. So the majority of clients that I see in the rehab side have probably, just as you said, been sort of between sort of 50 and 75. But
Yeah.
I am seeing, I've had a few women recently in their 40s that have started to come through with breast cancer as well.
Yeah, definitely. And don't be surprised if you also see some in their 30s. It's not our commonest presentation, but we do see them. And ultimately, we probably will get to this, but it's just understanding that when you have a lump or you've noticed a symptom, it's best to have it investigated and not sit on it assuming that you're not in the group that potentially could get it.
Yeah, well, I think that's a good segue. So I myself, 2 years ago, was just doing a breast check in the shower and found a small lump. Freaked out. I don't, that's probably common for many women to sort of, because you've never had one before. So
Yeah.
did freak out, booked into the doctor straight away. She calmed me down because she did a check and just went, I'm pretty certain it's not going to be anything, but still sent me off for an ultrasound and had it checked out, and it clearly wasn't cancerous or anything, but it did give me a bit of a shock, being sort of 38 and thinking, oh, I just didn't think that, it would present that way. And I check mine fairly regularly. So I would say in the space of a couple of weeks, and this was just over a centimeter. So it wasn't tiny, but it wasn't super big. And it surprised me how quickly something like that could develop as well.
Yeah, definitely. I think end of the day, it's balancing life with um, at a difficult time when there are a lot of commitments in life. Generally, it may have kids. It'll be looking after potentially a partner, potentially work, and finding the time to also be in tune with yourself as well, where there's not an umbrella net for capturing things. like screening generally starts above 40. It's recommended strong, like our screening program runs from 50. It's now from 40, but like less than 40, if you're noticing a lump, it definitely is important to get it checked. And the way you did it is great because you're checking yourself, so you're aware what your normal is. You've noticed a difference. It's highlighting you've noticed a difference and then got it checked out. Majority of the time it'll be benign or non-cancerous, which is great. But at least you're not sitting on something that potentially could be treated if it ends up being something.
Mm. And also, it did take a couple of months for it to sort of disappear or settle down as well. So, because, for a period of time there, I'm like, is it going to get bigger? Is it going to settle down? So, but, again, speaking with my doctor, she's like, if there is any further changes, then come back and then we'll go for an ultrasound. But she said it should just essentially sort of disappear, and it did.
Yeah. And I guess the reality is like with this, it's a question of are we doing well in society? We probably are. We're doing well, but what are our goalposts? Like how well do we want to do? And as a group, I think ultimately picking things early is key. I think to when we see patients, makes us relax if we are picking up cancers early. We will probably get to treatments, and treatments have improved, but it does help if we're picking them up early. So we're trying to understand and educate people to take ownership about their health and trying to be as proactive as possible in spaces where currently there probably aren't strong guidelines.
Mm. And when it comes to sort of, doing your own sort of breast checks, how often are you encouraging, people to do that?
So I generally would encourage monthly to check, minimum probably 4 times a year, like at the change of seasons. But generally, I would encourage monthly. And the timing in a premenopausal patient is generally around 10 days post the commencement of the cycle, so that things aren't as lumpy, everything's sort of settled, and that's generally a good time to check. With regards to the postmenopausal patient, that would be generally picking probably the first day of the month, something easy to remember, and just picking the same is a good way, just as a note for yourself.
Yeah. And when it comes to breast cancer, there are many different types, which, a number of years ago, before I started sort of working in the area, I didn't even realize that there were different types. But, when it comes to, genetic factors, lifestyle factors, environmental factors in the development of breast cancer, what's the sort of percentages, or how much is it genetic compared to environmental and lifestyle?
Yeah, it's really interesting because I think we subdivide them into modifiable and non-modifiable factors. And the modifiable factors, two of them you just can't change, which are being female commonly and getting older. They're two factors that are difficult to change. And they have, if you look at epidemiologically, a significant impact and with time relating to developing breast cancer. And then, so those two things you can't change. Genetics into play is a component of our cancers. And for the group that do have a genetic mutation, they are at a significantly higher risk, potentially, depending on the gene, of developing a cancer. But they aren't the largest component of patients that we see. So the potential thinking that I've don't have a family history of breast cancer, therefore I won't get breast cancer is not necessarily true. And then when we talk about environmental factors, I think there are things we can't quantify well, things we can't, like such as stress. Generally, it's hard to, how do you measure it? Exercise is difficult, but when you look at factors like obesity, and then you look at hormonal exposure over a period of time. So timing of first periods, timing of menopause, the amount of children, the amount of breastfeeding, over time, we do take these factors into play. And I suspect it's a reflection of hormonal interplay over a long period of time that does play a role. On a large enough group of patients, you will see a difference. Will it individually impact someone? Potentially not. But if you take enough patients, there probably is a difference there.
Mm. And, is there things like diet and lifestyle that you recommend to your clients to sort of, really be including regular exercise, eating a whole food diet that can influence our risk?
Yeah, I think like ultimately, and it probably goes across cancer streams, but eating whole foods, eating generally trying to avoid fast food where you can, like having a balance, like obviously once in a while doing something, but not making it a habit is okay, I think. And just trying to regulate your diet is very important. It makes a huge difference to chronic diseases, but also probably impacts with time your risks of cancer as well.
Mm.
And so like thinking about diet, think about vitamins, antioxidants, thinking about like you mentioned, exercise. And it's not about doing it over a week. It's about chronicity. So doing it where you won't notice a difference for 6 months, but if you can do it for a year, you'll start to, something that's pragmatic, something that you can take on, that you actually will do, and finding ways to motivate yourself is, I think it does make a difference.
Mm. And also, I have read some stats about alcohol, and especially alcohol being linked to increased risk of breast cancer in women.
Yeah, there definitely is an association with alcohol. I think the key is like you're trying to live life, you're trying to find ways to de-stress on the weekends or have time with your colleagues, and but then you're balancing it with moderation, I think. So ultimately being able to moderate the amount and how often you're drinking, both from a weight perspective, empty calories, but also from a health perspective is important.
Mm. Well, even just, when you're having alcohol, it means your liver can't work as effectively. You've got to detoxify. It just means all those processes that are usually happening in your body, it's going to be harder for them to do.
Yeah. And then if you take large volume stats, it makes a difference.
Mm. And when it comes to sort of treatments nowadays, can you explain some of the treatments that are now available for women?
Yeah, definitely. So we could subdivide breast cancers generally. I might actually go broader than that and just start with the big groups to start. So we talk about surgery as a type of treatment for breast cancer. We talk about chemotherapy as a type. Then separate to those treatments, so chemotherapy is often given through a little port that's connected to your vein. And then we talk about radiotherapy as a third big type. And then depending on the type of breast cancer outside of chemotherapy, which treats the whole body, we are talking about targeted treatments. And those treatments could happen at the time of chemotherapy, or they could also happen in the form of tablets, which are targeted treatment to our receptors. And so it's a mixture of surgery, some sort of treatment of the whole body, and a local treatment, which is radiotherapy, that makes up treatments for breast cancer. And I can go into more detail from there.
Yeah. So obviously depends on what type of breast cancer you have as to what treatment you will need. And I'm assuming the sort of lengths of treatments will vary as well.
100%. So like earlier that we find the cancer, the likelihood of reducing the amount of treatments and thinking, oh, what can we actually pull back on, comes into play. But generally speaking, when we're talking about our treatments, we break the breast cancers into three types. The first type is a hormone positive type. The second type is one that has a specific receptor called a HER2 or HER2 receptor on it. And the third type is one that doesn't have the two hormone receptors or the HER2 receptor, that we call a triple negative breast cancer, or basal type commonly. So those three types have different treatments. So if we were to take, for instance, start with the hormone positive type as the first type, we break them up into two types. We break it up into a slow growing hormone positive type, and that generally we would start with surgery. Then we would go to potentially radiotherapy if they've had a lumpectomy, but no radiation if they do a mastectomy. And then afterwards, they would have a tablet, and potentially that would run for 5 years, which is blocking estrogen. Now, that particular type, so the second type of hormone type is one that's faster growing hormone type. And with that one, there may be a role for surgery first, or there may be a role for doing it the other way and starting with chemo first and then doing surgery and then going to radiotherapy and then still going on the tablet. And the duration would vary depending on how much volume of the lymph nodes are involved. Within that group, we've actually got other agents we're using. We're using bone improving medications that improve the bones that actually probably help the cancer treatment. And we're also using other novel hormone blocking tablets, one that got through this year called abemaciclib, or a CDK4/6 inhibitor. So that's another type we're using for higher advanced hormone positive high-grade tumors. So that's the first type of breast cancer. That's probably the most common type of breast cancer. Then the second type is one that has the HER2 receptor or HER2 receptor, and that's likely, even if it's hormone positive, it's a likely receptor that's driving the cancer. And for that type, our treatment often flips. So we don't tend to operate that often first. We tend to give them targeted treatments that target that receptor and often use two agents, often Herceptin and Perjeta. And then that will shrink down. We will operate, and around 6 to 7 times out of 10, there will be no tumor at the time of operation. But if there is residual disease, we are using other agents afterwards. So part of the advantage is that it's reaffirming the benefits of those targeted treatments. But secondly, if we are separating out the tumors that respond and the ones that don't respond that need other treatments early. So we're then giving, for instance, TDM1 afterwards, which is another strong targeted treatment for that particular type of cancer. And then they go to radiotherapy and the TDM1. And then the third type is the triple negative type. Again, historically a poor prognostic cancer. And generally we've gotten better at finding treatments for this group, but we would start again with potentially chemotherapy first, plus if it's in the lymph node or it's greater than 2 centimeters, we tend to use immunotherapy now for this group. And we're fortunate that we have 5-year data from Keynote 522, which is a study that demonstrates the improved outcomes with this group by using immunotherapy in the larger groups of cancers in this group. And what we're seeing is that around that 5 out of 10, when we operate, there's no cancer left. We are cognizant that with the immunotherapy, there are side effects from the immunotherapy. So that's why we don't use it on every triple negative. If they're really small, we may not use it and just stick with standard chemotherapy. But for the larger than 2 centimeters or lymph node involvement, we are using it. And the responses have been great. From a surgical perspective, we have to be cognizant of the immune effects, and we do check bloods prior to surgery in that group and make sure that their hormone levels, including cortisol levels, are checked. Then they'll have surgery, and then they'll proceed to radiation afterwards. So that's your basic treatments. But just to throw in there, in the hormone positive and also particularly in the triple negative, we have treatments for the group that do have a genetic mutation. So commonly in the triple negatives now, we are mainstream genetic testing, which is testing through the surgeons and checking if there is a genetic mutation so that post-treatment, if there is residual disease, we will then give a specific gene specific medication called olaparib, and that's come onto PBS this year. So we've gotten very refined. We're getting great outcomes, but still a really important thing is the earlier, the more successful in terms of treatments.
Mm.
And we
Well,
haven't gotten into, like, obviously we are de-escalating as well. So part of it is who are the ones that need all that extra treatment? Who are the ones we can pull back the radiation, for instance? So the older patients that have small tumors, maybe we don't need to irradiate. The ones that are slower growing, that are small, maybe we don't need to irradiate after surgery.
mm. Well, I did have a client, so she's now in her 80s. She had breast cancer in her 60s, and so she had a double mastectomy, and she had chemo at the time, and then they offered her radiation, but she said no thanks. I've had my chemo, I've had my double mastectomy, and they gave her the statistics to see if it would return, what percentage it was, and so she waited up for her and decided not to go ahead with it. So it's nice to hear that there are lots of options for people and that it is just expanding and changing.
And we are finding, okay, who are the ones we can reduce? Who are the ones that we can be more refined with our treatments, being cognizant of the side effects? And I think we've moved slightly from a paternalistic model to a mutualistic model where we've got the patient in the middle and working with them around their options. Often a discussion isn't one consultation to start. Often my first consultation is telling the patient, look, you probably won't remember a lot from this, and we will see you again, but you just need to know that you've got good people around you that will work with you around the options and hopefully take some of that pressure away early.
Mm. And with the gene testing, I know it's become a lot more sort of standardized. I've had clients that have had their daughters had breast cancer, and then other members in the family have then been tested to see if they have the genes. But can the average person go and get a test, or is it usually just when, you might have a family member that's been diagnosed with breast cancer that would occur?
Yeah, there are ways of like working out the likelihood of a mutation. And like really, you're eligible for publicly funded testing if the likelihood is above 10%. So there are scoring systems in place. But the best thing to start would be to probably see a GP, see a clinician who can work out the risk. Generally, the yield, the bang for buck's probably less high if you're below that 10% threshold. And it's not currently, strongly done but you could potentially go and have and pay for the test, but without a family history, it makes it less likely that you will have a genetic mutation.
Yeah. And if somebody, there's a listener listening, they've been tested, they have found that they do have the gene, the BRCA1 or BRCA2, is there anything extra that they need to be doing or be aware of so that they can help prevent the onset of breast cancer?
I think having the gene and particularly the BRCA1 or 2, BRCA1 or 2, but there are other intermediate risk genes as well. I think it's understanding that your surveillance is an option, but the idea of prophylactic surgery with the possibility of avoiding other treatments if you do develop a cancer are on the table, and having those discussions. It's understanding the role and what sort of modalities we'd use for surveillance, and that would include potentially MRI as a screening tool, which is a functional assessor of the breasts outside of just mammogram and ultrasound, and then on top of that, thinking about the ovaries as well. And with ovarian, it's harder to screen the ovaries. So thinking about, post kids, where does a prophylactic removal of ovaries fit in those two groups?
Yeah. And a client recently, so her daughter had breast cancer, and so the family was tested, and she's said her son has the BRCA. I'm not sure if it's BRCA1 or BRCA2, but she said he has the gene. So she said she's concerned about that. Is there a difference between, male and female developing breast cancers if they find they have the gene?
I think you have to be cognizant, yeah, that if you are a male, there's still a risk of breast cancers. We are seeing a few per year. So clinical examination is important. You probably don't need routine ultrasound, but just being really in the male, you just have to be very specific about checking whether or not there's anything, you're noticing any lumps. If you do have any swelling generally, some patients have gynecomastia, there is a role for imaging in those groups for assessing to see if there's anything concerning. But on top of that, the other considerations with BRCA2 is pancreas as well. There may be a role for assessing the pancreas and prostate with time.
Mm. And we had a family friend recently. I may be using the wrong terminology, but she'd had a mammogram and again, they'd found a lump. It was non-cancerous and she'd had it happen a few times. So she had a small surgery where they inserted a seed, if that's the right terminology. Can you explain a little bit more about what they are?
Yeah, so we've moved from, if we think about our surgery, we've moved from basically, if you think about surgical options, we're talking about how do we know what to take out, like if we can't feel it. So we've got the surgeries where we can feel a lump and then you don't need to localize it. But then you've got the group where you can't feel it because it's potentially too small but needs to be removed. And in that group, historically, we've used a hook wire, which is a wire that's inserted on the day of surgery. Then the patient comes up and we trace that wire and trace it down from the skin and take out the tissue around the wire with the clip potentially in the middle or the area that needs to come out in the middle. But there's now a number of wire-free technologies which stops the wire from being placed in. A seed is one type of wire-free technology, which is a magnetic type of seed. It's quite a neat way of doing it. The other, and it's probably one of the earlier non-wire-free technology. The other technology we use, and one we're using probably slightly more, is using a radar clip, which is the same technology. It has a small antenna, same technology as at the airport, and the antenna is picked up with a beeping machine, and it allows for us to take out a grain of rice level because of accuracy. And there are a number of other magnetic seed options on the table as well that are there. But it's nice when industry have developed to provide better options potentially for patients. And what we've seen in our studies with radar technology, as an example, is that we've reduced the amount of tissue we're taking. We've reduced our re-excision generally by meaning having to go back by using this technology.
Well, that's, amazing with, recovery times and pain and all of that as well for patients too.
Yeah, definitely. I think it is. It's nice that when companies come to you, you always are concerned that is it an oversell? But like with regards, it's nice when the technology meets what we need to improve the patient experience.
And going forward, in this field, what are some of the new advancements that are coming, or what are you hoping to see will start to come, in the next 5 or 10 years?
Yeah, look, I mean, if we really go far enough, and far enough in the future, you've got to, as we improve our oncology experiences, I think maybe surgery in certain patients could potentially come off the table. Like it's all about the patient. So ultimately, in the ones that are very sensitive, we could potentially look at maybe, doing other ways to remove those early tumors. When we're talking about other things, it's about de-escalating again. So less radiation in the groups that probably radiation's great for breast cancers, but the group that probably don't need them, it's nice to be de-escalating that away for the group that don't potentially need it. I mean, our aesthetics have improved as well in terms of surgery. So there's a bigger focus and we've come a long way in the last 10 to 15 years in terms of aesthetics. And now there's a bigger focus on function as well. And as you would know, we're doing a lot more rotational flaps, and with that to try and keep the shape, but we've got to make sure we're aligned with our multidisciplinary groups to assess function and adapt early, not just to arm swelling, but to breast swelling as well. So both are improving. And with regards to even in the reconstructive spaces, we're looking at function as well. We're generally, when we're doing mastectomies, preserving nerves as well on top of, but, you know, and moving own tissue in certain patients that are appropriate. So there's a lot of advances with the idea of form and function.
And in the sort of breast cancer space in surgery, are robotics coming into play?
Yeah, we're seeing we're definitely we did probably about 10 robotic mastectomies earlier, and then the technology wasn't really fitting what we needed for breast. But like soon there will be a machine coming which is a single port. So I do see it with time coming, and probably where the benefits would lie would be, I think a lot of the benefit would be probably scarring, but more of it would be for the person doing the surgery, because your neck from bending down and doing the mastectomies, I think ultimately what you'll see is less chronic use of the neck and manual issues. So I do see that coming in with time, but there will be a learning curve, essentially, like we've seen with other specialties like prostate. The reality is it's balancing with innovations, making sure that we're doing it in a controlled way, assessing the potential benefits of new treatments, and making sure we're, keeping patients informed and ensuring that they're not being harmed with the new treatments as well, which is the balancing act on as we continue to develop. But it'll happen, I think.
Yeah, it's a pretty, I think technology-wise for the whole world, it's an exciting time, and it's just exploring how we can use this technology in different areas.
100%. Yeah, I would 100% agree with that.
Now, I would be remiss to not bring it up, but, a little while ago in the news, Elle Macpherson came out and said that she'd had breast cancer and, kind of described what she had done for treatment, which was very different to sort of the regular, I think, options that are presented to the average patient. Do you have any thoughts on that?
Yeah, I do. Look, I think firstly, with Elle's personal experience, we can't, it's hard to personally comment on her own experience, but we can go by the information we've got, what she has said. And firstly, I think we're hoping she's doing really well. We hope she does really well long term. She's done a lot of things in her life that have, made a lot of changes in her life positively. So I'd want to put that out there to start. And she looks great. The concerns relate to, firstly, the type of cancer, from what we can gather from the information that we've got, appears to be one that we probably wouldn't give chemotherapy to in Australia. It appeared to be precancerous, is the information that has been fed through and from the best light we've got. And if it generally, our concerns more relate to other people seeing that and thinking, okay, Elle has done this, therefore I may be able to do it. That's a concern. And the concern's more when we know we've got great treatments for patients. The difficulty with being diagnosed with anything that you're foreign to is taking on treatments that you lose control a little bit with a diagnosis, and then you're seeing people, you're trying to work out who to trust, and then you're trying to work out the pros and cons of things, and it can be very difficult. And it's a time where you're meeting people and trying to work it out. And I think it's important to work with medical professionals, keep them part of your team. I personally felt that it's important to understand when people are pulling away from potential treatments that you have to support them as a medical professional to try and get them to understand the potential benefits of treatments and what potentially could have if they don't take it on. So, but without necessarily pushing them into a corner. It can be difficult for certain groups. And I think where it goes against their general philosophies. But I don't think all medical professionals generally are trying to work with the community to improve their likelihood of quality of life. And particularly with the groups where we've got incredibly sensitive treatments, it's important to understand that our modern medicines are the thing that will cure a number of these cancers. They don't do it by themselves. It is important to exercise, eat well, do things on the side that improve the microenvironment, reduce stress. But the tumor treatments are often from medical treatments. And having something that works synergistically with that is a nice pathway. Yeah,
And I
so
think I was going to say, I just think as well, hearing somebody else's journey it's nice to hear, but it may be very different to your journey because it does depend on the type of cancer you have, how far advanced it is. A lot of these other things come into play as well.
yeah, definitely. And like I think that's the key. I think there was a strong um, response from the medical community when Elle came out, not with the goal of necessarily criticizing Elle's experience, but more making sure that people in this scenario are taking on best options and understanding that their experience may be very different and understand the pros and cons of each at that time when they potentially have curable cancers.
Mm. Well, I think it's just one of those things you've got to have, really clear communication with your health professionals, have open discussions, find out all your options, and find out as much information as you can and really find trusted sources too that you can get that information from.
Yeah, definitely. And there are a number of trusted sources out there, like we have Cancer Network Australia. We have our website has some information on it. There will be Cancer Australia. Sydney Breast Cancer Foundation is another group that have information on it. There are multiple good sources, and it's just making sure that you're looking for trusted sources, working with your health team that have spent a long time understanding the pros and cons of treatment, and making sure you're making decisions with the team around you. And it's important we don't work in silos, we work in ecosystems. We don't make singular decisions. We try and work within a community that can help that particular patient.
Mm. And we've covered quite a bit today, on prevention, on treatment options and the future. But is there anything else that you'd, like to leave listeners with to highlight?
I think it's like the big thing for us is that we're fortunate to have well-trained surgeons in Australia. Like we've got a good quality of breast surgeons across Australia. And if you are diagnosed, I do feel it's likely you will get good care in Australia, but basically make sure that they're appropriately trained, obviously, and but work with your GP, work with trusted information, and make sure to keep doing checks, be vigilant, and yeah, wish you the best moving forward.
Amazing. Now, before we wrap up today, where can our listeners, reach out or connect with you?
Yeah, so probably the easiest would be on my website, which would be drsanjaywarrior.com.au, which is and then through my practice, I'd be more than happy to, take questions, etc.
Amazing. Well, I'll link that up in the show notes. So listeners, head across there if you'd like to connect. But thank you so much for coming on the podcast today. I think this is an area that, the more information that we can get out there, the more prevention that we can get, the better it's going to be for women and men, and just, overall for highlighting the awareness of breast cancer.
Thanks, Katie. 100% agree.